Yep. So if you're joining us on Facebook, hi guys, and we're just getting ready, a few people loading up, and we're just getting ready for the other social media apps to get loaded and started. And there we go. So we should be live on Twitter, YouTube, Facebook, and Instagram. Those of you who are joining us on Instagram, we did have trouble last week trying to make sure we got sound. Can you just give us a shout out and tell us that we have sound? And that way we'll make sure. No one's saying anything yet. Can you guys hear me on Instagram? Is there sound? Yeah? Yeah, everybody's giving us the thumbs up. Awesome, loud and clear. Okay, so we've got the glitches worked out. That's really good, and that's amazing. So welcome to Fertility Fact or Fiction. I'm Dr. Rahi Victory. I'm a RE, and those of you who have been watching the show for the last couple of months, thank you for your support. And we have an amazing show for you tonight, a really interesting topic about whether or not melatonin impacts your IVF success rates. And I'm going to go over that. And then we have the question and answer period for you guys. And we're going to go through the topic. And at the end, we are going to say whether or not it is a fact or a fiction that melatonin helps. So thank you for joining. And we're going to go through our segment in just 1 second. Okay, so once again, thanks for joining. And we're really pleased to be back with all of you tonight. Super excited to have the opportunity to do this every week with you guys. We love the questions, love the opportunity to share with you guys any information that we get, and the opportunity to reach out and help those who need answers and aren't getting them or have the difficulty finding them on their own. That's what we're here for, to do the research for you, or at least be able to answer what we can for you guys. And thank you, as always, for your comments and your likes, and any suggestions that you have, we're always open to. So we are more than happy to address those. Make sure you subscribe on YouTube, and follow us Facebook, Instagram, Twitter. We are available to all of you. Thanks to all of you who send us the well wishes as well. Amazing of you guys to be so supportive. So thanks for our whole community here. Okay, so interesting topic I came across this week, and I won't make it too long, but we wanted to review whether melatonin can be helpful in IVF. So this is an interesting topic because the hormone melatonin is a ubiquitous hormone, and it's actually present in almost all living organisms. It's very ancient. It's been around for a very long time, and we know that it can help different people and has a number of different sort of physiological actions. It's controlled by melatonin stimulating hormone, or MSH, or melanin stimulating hormone. And we know that it can definitely affect a variety of different physiological functions. A lot of you are probably familiar with it because people believe it helps you sleep. And there is actually fairly good information and research out there, data available, that supports the fact that it can improve your sleep function at nighttime if you're having difficulty sleeping. For infertility, they've tried it in a variety of different scenarios, and we know from animal studies actually that there's pretty good evidence that it can improve your egg quality, both in pig models and in mouse models. In human models, there was a study that had been done where they combined it with myo-inositol and compared it to just inositol, and this was done back in 2016. The title of the article, I'm not sure if you guys can read that because it's probably backwards for you, but I'll read it for you. It's Effect of Myo-inositol and Melatonin versus Myo-inositol in a randomized controlled trial for improving in vitro fertilization of patients with polycystic ovarian syndrome. So we've talked about myo-inositol before on the show, and myo-inositol is a supplement that can help in patients with PCO. If you're not already using it, you definitely should. And here they added in the melatonin to see if that can also be of assistance. So in that study, it was actually fairly large. There were about 526 women, all who had PCOS. And what they showed in that study was that they applied the two groups. So you were either on myo-inositol or you were on myo-inositol with the melatonin. So just looking at it, they had about a 4,000 microgram dose of myo-inositol. They had a 400 microgram dose of folic acid, and then a 3 milligram dose of melatonin. That was group A. Group B was myo-inositol, 4,000 micrograms, and just folic acid. And then they had a control group which didn't have anything but the folic acid, so they weren't on the myo-inositol or the melatonin. So if you look at the results, they did show that there were more mature oocytes revealed or retrieved when they did the egg retrievals, and that was highly significant. So it was 48.2 in the group that used the myo-inositol versus 35 in the group that used, the myo-inositol with the melatonin versus the group that used just the myo-inositol with the folic acid. So that's quite a substantial difference, and that was very highly significant. The p-value, which is how we assess how valid or important or significant the information is, was less than 0.001, and that's a very significant number for us. That tells us that's a real measurable, substantial effect. The other factor that was quite important was that they had a higher percentage of what they classified grade 1 embryos, and these are really the best embryos that can be derived from a cycle, and that's based on morphological scoring. So you're looking under the microscope, you're assessing both the trophectoderm, which subsequently becomes the placenta, and you're assessing the embryo itself, or the actual portion of the embryo that is going to become the fetus or the baby. So between those two segments, they score the embryos, and they have a percentage that they say are grade 1 through 4 embryos. So there was almost a 50% difference. In the group that had the myo-inositol and the melatonin, 45.7% of patients had grade 1 embryos, which is really quite amazing. That's a high percentage of high quality, top quality embryos, versus only 30.4% in the group that did not have the melatonin. So it really is a very significant impact. And again, that was highly significant. The P was less than 0.001. So for that specific group, it definitely appears to improve things. There are other studies as well. So I'll just kind of read the titles to you, and we can go over the results either later tonight or at another time. Oral melatonin supplementation improves oocyte and embryo quality in women undergoing in vitro fertilization and embryo transfer. That's from a Japanese group. It was published in 2014. And there is another study from 2013 that looked at whether it improved the outcomes when you added the melatonin into the culture. So that's where you're pouring it into the fluid that the embryos are being grown in, and that too appears to improve the success rates. The other studies start to get a little bit older, but there is definitely evidence that it is improving the overall success rates, including things that are sort of involved with or derived from the embryo growth, the oocyte growth, the development of the eggs themselves, the number of blastocysts that we're getting, and as I mentioned earlier, the quality of the blastocysts that we're getting. The really interesting thing with melatonin appears also to be that it may be helping with frozen embryo transfers. Whether or not it's because you're sleeping better, I don't know. That certainly may have an impact. But there actually is evidence that melatonin has multiple actions. And one of the actions is that it is very good at being sort of anti-inflammatory and as an antioxidant. Antioxidants help to reduce the amount of damage that is being done either by oxidative species, which are things like oxygen atoms where the two oxygen atoms have been pulled apart. And so one of them has what's called a free radical, and that can do a lot of damage to DNA and to tissues. And you can get higher levels of those from environmental toxins, smoking, exposures. Even things like obesity can cause higher levels of oxidation or oxidative stress. So melatonin is thought to actually reduce that because it works as an antioxidant. And anything that reduces your oxidative stress is inherently going to be anti-inflammatory and help improve the chances of success by reducing the impact of your immune system, reducing that oxidative damage. So to sum up, the overall data is an assessment of whether or not melatonin appears to be beneficial. And overall, so far, looking at the major trials that have been posted to date, and I always search based on randomized controlled trials or meta-analyses and review articles, it does appear, fertility fact or fiction, that melatonin does improve your success rates and you should be using it. The trial that I mentioned before used that 3 milligram dose. And so that's a very reasonable dose to start with. You can probably pick this up at any pharmacy or health food store. So use your melatonin. At the very least, you're going to sleep better. And at the most, you're actually going to see reduced oxidative stress, reduced oxidative damage, and improvement in your immune reactivity, and hopefully a higher chance of getting more mature eggs, a higher fertilization rate, and more top quality embryos. So that's our fertility fact or fiction for tonight. Yes, it's a fact. Melatonin does appear to improve your success rates. And if you want any more information about it, don't hesitate to reach out to us. We will be happy to get back to you on details with regards to that subject. So I know it's question and answer time now. We always like to take questions from our audience, and I'm open to that as always. Again, make sure you're liking and sharing with your friends. We want to make this the best show available for fertility. So I am more than happy to take any questions. So someone's actually just asking on Instagram, are there any negative effects of being on melatonin in the long term? None that I'm aware of. I don't believe there are too many long-term melatonin studies, but there shouldn't be any significant impact. Melatonin, as I mentioned at the start of the show, is a ubiquitous hormone. It's in almost every living organism, has numerous functions. You need it in order for it to normal sort of daily bodily functions to occur. So there shouldn't be a problem with being on it. Certainly, I wouldn't recommend taking excess levels of the hormone, but for normal levels, you should be perfectly fine and there shouldn't be any risks. Okay, so going back, we're going to go to Facebook, and the screen might shake from time to time, so I apologize if it does. It's me trying to scroll through the questions. Okay, so from Facebook, we have a questioner who says, I get pretty intense ovulation pains and can pretty much feel the exact moment I ovulate. I know it is from ovulation because I had it confirmed by ultrasound, and my LH is always peaked during the pain. What does it say here? Some say, I have heard mixed things. Some say it is totally normal. Others say it shouldn't be very painful. Is this a problem? Could it be hurting my chances of conceiving? Is it actually normal? That's a fantastic question. So thank you for asking that from Facebook. Hi, guys. And the answer is most women can have some sense of when they're ovulating, and that is pretty normal. There are many women who will sort of experience a little bit of tenderness or cramping, and in some women it can be very severe. It doesn't necessarily mean that there is any concern or pathology there if you are feeling that kind of pain. However, if the pain is always there or it persists throughout the rest of the month, or if you're experiencing pain with, let's say, intercourse or with your period, that would then make us a little bit more concerned about the potential for this to be endometriosis and not just the pain from ovulation. Painful ovulation is actually called Mittelschmerz. It's a German term which just means pain in the middle. And so we are very accustomed to hearing about Mittelschmerz, but it is possibly pathological only when we really see that you are suffering other aspects of it. So I wouldn't worry if you have a little bit of pain and you know that it's concurrent with your LH surge or with your ovulation occurring. That's probably very normal. Some women are very attuned to it, and that's completely fine. But if you're having other pain symptoms with it, so painful periods, painful intercourse, make sure you get checked out to assure that it's not endometriosis, because endometriosis definitely can alter your chances. Okay, sometimes in my cycle I have a light spotting. Only does this will affect success to conceive naturally. 41 here. Yeah, so spotting can be sort of just dysfunction of the lining of your uterus, but it can also be a polyp or a fibroid. So it's important to investigate spotting during your cycle. If you are having spotting during the cycle, we want to make sure that you're getting what's called a saline infusion sonohystogram and an appropriate hormone panel, and that will kind of show you if there's anything in the uterus that's of concern. I am really excited to announce tonight that we just did a video with a live patient showing a saline infusion sonohystogram. I know there's tons of women out there that have read terrible things about how painful it is and how horrible it is. If it's done properly, it is completely not painful. It can be done very gently. If you inform the patient and you use the right technique, it's a perfectly safe procedure. So we're going to have that video on YouTube and Facebook, and it'll be up this week for you guys, and you'll be able to see that, and we'll put a link to it in our Instagram as well. So hopefully you guys will watch that and see that it doesn't have to be scary if you're having an SIS. Just make sure your doctor does it in the right way. So yeah, make sure that your spotting is checked out. If it's a polyp or a fibroid, it can significantly reduce your chances, especially if the fibroids are in the cavity of the uterus. Otherwise, it's not a huge concern. Someone's saying, would you consider melatonin for natural conception? It looks like it's actually great for conception. So I think it's a fantastic hormone to use. Very few side effects, and it does not appear to have any downside that we are aware of right now. Okay. Can you have a period each month and not be ovulating? Ooh, that's a good one. Yes. So there is a huge difference between bleeding and ovulation. Normally in a cycle, your pituitary gland sends out the signals to your ovary to start growing an egg. That then produces estrogen from the egg, and then you get enough estrogen that your brain says time to release the egg. It sends out the LH signal. The LH causes the egg to release. The cyst that's left behind in the ovary from the egg release starts producing progesterone. And if you don't get pregnant, your progesterone level begins to decline, the lining becomes unstable, and you have a period. So that's what's called an ovulatory cycle. But if you get very high levels of estrogen, the lining will grow, and you can get estrogen not just from an egg, but actually from your adipose tissue, so the fatty tissue in the body. Your adrenal gland can produce androgens, which can also be converted to estrogens. So if you are getting extra estrogen but no progesterone, the lining can become kind of so thick that it outgrows its blood supply. And if you outgrow your blood supply and the lining is too thick, the problem with that is that it becomes unstable and the upper portion of the lining can actually begin to shed. So that is very frequent in women with polycystic ovarian syndrome. Now, you don't typically get a regular period in that scenario. The periods tend to be more irregular, but there are women that get fairly regular periods within sort of a 35, 40-day cycle, and they are not ovulating. And that's risky because remember, with no progesterone, you're getting unopposed or sort of continuous high levels of estrogen exposure, and that is a risk for what's called endometrial hyperplasia, atypia, and then subsequently cancer. And these are the stages of what you go through in order to get from sort of basic lining all the way out to developing cancer of the uterus. And it is risky. So make sure that you are ovulating. Not everybody is necessarily ovulating when they're having a bleed on a fairly regular basis. Okay, I'm not sure if we've seen any questions on Instagram. Let me see if there's any there. Would I recommend melatonin for a frozen embryo transfer as well? Still the 3 milligrams? Yeah, I would. I think that it likely is going to be beneficial to take melatonin, and that the 3 milligram dose certainly seems very reasonable. I'm going to start doing some more investigations, having read this, to see what other data is out there. But this definitely seems like it's a very reasonable dose and the appropriate first step, because there's data for it. So anything where there's information and somebody's already tried it, that's a reasonable thing. Okay, so we have another question from Instagram. After multiple attempts of retrieval and then multiple failed embryo transfers all within the past year, is it possible a woman could be experiencing a level of postpartum depression? Wow. So postpartum depression is subject to significant withdrawal of the hormones in the body. You may be mimicking some of that, but it would be much more sort of up and down with a IVF type of scenario. But it's possible. However, it's definitely known and well established that women going through infertility, and men as well, and as a couple also, that the stress and the anxiety can definitely cause depression. So if you've had multiple retrievals, multiple embryo transfers, and I'm very sorry to hear that they haven't been successful, there is no question that you need a lot of attention, not just for your medical care, but also for your psychological, emotional, spiritual state as well, because those are very important. And as physicians, we need to make sure that we are not just treating you for the medical component of what's going on. We also need to be treating you for the holistic component. So your well-being, your health choices, your diet, your exercise levels, your relationship with your partner, and then of course the whole psychological, emotional, spiritual component of this. So all of those are really, really important. Okay, how likely am I to succeed with first round IVF with PGT testing? I can only afford one round. I have my first appointment next month with you. Oh, well, I'm super happy to hear that you're coming to see us. It depends on your age. I love these questions every week about how likely things are. It's very difficult to answer these because I need to know specific details. How old you are, what the diagnosis is, how long you've been struggling, what the sperm quality is like, what your lifestyle habits are, and so on. But bottom line for PGT, so for those of you that are new, that's pre-implantation genetic testing. There is very good evidence now, and we've presented Fact or Fiction on this before. It should be up. Tarek, is that up already on YouTube? So you can watch one of our previous videos about that. You should not be getting pre-implantation genetic testing unless you have failed multiple previous cycles, you have recurrent failures before of implantation or recurrent pregnancy loss, or there is a known genetic defect in you and or your partner. If you are under the age of 38, doing the PGT is not only not helpful, it actually may be detrimental. So we don't recommend that you do that. Okay, I'm going to flip back to Facebook for a second. I have PCOS and I've been told I have lots of healthy looking eggs and my tubes look great. I have spent thousands on Gonal-F injections mixed with letrozole and metformin, but have not gotten a follicle over 10 millimeters. I'm very discouraged. Any recommendations? That's highly unusual. So I would want to know more about your status. So if body mass index is a concern, are you using inositol? Are you using N-acetylcysteine? Your exercise, lifestyle habits, those are really critical for that question. But it would be very unusual to not be able to get an egg to grow over 10 millimeters unless there's something else going on. So recommendation wise, I would say look at doing the cycle without the letrozole. Try just the Gonal-F, and then it really depends on the dose. So you may need to start at a higher dose. I'm definitely sorry to hear you're spending so much money. Meds are cheaper in Canada. I don't know if you're in Canada or the US, but we really want to make sure that you're not sort of taking on too much cost burden here just to find out if it's going to work or not. But there should be ways to mature your follicles. There are lots of tricks we can use. There are microdose Leukeron flares. Some people use letrozole. There's estrogen priming. You may need to be on some androgens. So sometimes testosterone can help you make more eggs or help them develop. Maybe again, the melatonin seems to be increasing the number of mature eggs. So that might be a suggestion for you in this case too. So kind of a lucky chance that that came up tonight. Definitely reach out to me if there's more I can help you with in that scenario. Very, very unusual. I do remember one case years ago where we had a lady that would actually make full-sized follicles. They would get past 10 millimeters, but no matter how long we waited, and we tried 3 separate times, the eggs would not actually mature. So she had large follicles, but they wouldn't mature the eggs inside, and we couldn't really figure out why. She happily had 2 children later, but she used donor eggs, and we were successful for her. So there are times where it's more difficult than normal. Great question, though. Okay, my last ultrasound during my last miscarriage stated I had a 1.7 by 1.3 centimeter deep intramural subserosal fibroid in the left lateral body segment of the uterus. Is this normal? I just recently read that ultrasound report and nothing was ever mentioned by my OB about this. Okay, so fibroids can have different locations. So if it is in the cavity, that's called submucosal. Definitely bad, no question. Everybody agrees. Big decrease in your success in terms of implantation, and a huge increase in your miscarriage. So if you have a submucosal fibroid, so part or all of the fibroid is in the cavity of the uterus where your baby is growing, where the endometrium is, you need to have that removed. If it is intramural, so it's now in the wall of the uterus, it's a problem if the fibroid is large or distorting the lining of the cavity. So if it's kind of bending the cavity, it's sort of making it indented because of the pressure from the fibroid, that's definitely a problem. You also probably want to get rid of those. And in particular, there's some data that if they're over 4 centimeters, it can have an impact. There's also studies that have shown that if you remove the fibroids, the success rates improve. If it is subserosal, that means it's just under the sort of outer layer of the fibroid, which is inside your pelvis. Typically, those have no impact whatsoever unless they're absolutely huge, in which case that can have problems once you're pregnant with pain, obstruction, compression of other organs, or even if you're not pregnant, if they're very large, it can do that. So for sure, the one that you have being 1.7 by 1.3, it's intramural subserosal, that's towards the outer edge of the fibroid. I would not be concerned about that at all. That should be completely fine. Okay, here's a great question. What am I to expect during my first appointment with you that I have coming up? So excited and super nervous for this process. Okay, so first of all, I'm super excited to meet you, so that's great. We look forward to every patient encounter because I get to meet amazing people out there, and it is an absolute joy to be able to help people through this process. So we are excited to have you on board, and I look forward to meeting with you soon. In terms of what to expect, a detailed history, sometimes taken by me, sometimes taken by one of my staff members. We really go very much in depth into how long you've been trying, what's your journey been like for you, what sort of things have you tried? Have you seen another physician? What testing or treatments have you had done? And then a really detailed look at your personal history. So your medical history, your surgical history, your family history. Have you ever had surgery before? What happened at your surgeries? How did you react even to anesthesia? We really take a detailed look at everything. Your allergies. We do take a look at your body mass index, your height, and we definitely in detail go over habits. So whether you're a smoker, a drinker, a drug user, those sorts of things, marijuana use as well. And then we go through a detailed analysis of infertility in general. So I'll kind of explain to you how infertility affects people and what the sort of main core elements of it are and how we test for those things. We explain what we're going to do when we see you later on. So we go through all of the details of, what kind of visit we're going to have when we follow up with you, what test results we're going to go over, and how we're going to present those to you. And then once we've done all of that, I definitely spend some time chatting with you about the psychological and emotional burden. It's really important to us that we take care of you as a person, but also you from a holistic standpoint. And that includes your partner if you're here with a partner as well, so that we're treating you, your partner, and you guys as a couple. So we definitely deal with that. We present you with our resources to help you through this journey. And if you need any help in that regard, we start it right away because that's a critical component of it. Big shout out to Organic Conceptions, which is the online program that we use. Those guys have put together just an amazing program. We at our clinic pay for it so that all of our patients get it for free. So you're not out anything. You can do it from the comfort of your home. So it's really an awesome approach to helping people navigate the emotional, psychological journey that's involved here. Okay, here's another one. Just back to fibroids really quick. Do fibroids actually have a hindrance upon a woman's staying pregnant past first 7 weeks? I've seen cases where women succeed through full term pregnancy and healthy baby deliver. So same thing I just discussed. It really very much depends on the location. There is no question that not all fibroids are going to cause a miscarriage. So it's not 100%. It is a significant increase in risk of miscarriage, about double. But it's not a sort of absolute fact that you're going to miscarry when you have fibroids that are large, or even if they're in the cavity. I remember one case we had where the woman had more fibroids than I could count. I told her she absolutely should consider using somebody else's uterus with the embryos that we had created for her. She insisted that we use her uterus only. She did not want to have surgery because, quite frankly, there were so many fibroids it never would have worked successfully. We would have ended up doing hysterectomy. And we did the embryo transfer, and she did get pregnant and had the baby. So she was right all along. She knew her body. And we need to listen to you, and I always do. So, you know, a lot of women know their body and their abilities very well. We certainly need to discuss the science with you and review the stats, but if you feel really strongly about what you're discussing or experiencing in your body, for sure, we're going to listen to you and we're going to work together. So fibroids can impact your staying power for pregnancy, but not always. Okay, back to Facebook. Do you happen to know when the Windsor IVF clinic will be up and running? You know what? Next week we should do a tour. You know what? Next week at the start of Fact or Fiction, let's take everybody on a tour. So the lab is almost done. All the walls are up, the doors are up, the furniture's in, the crash cart is there. We're getting everything ready. Should be in the next 2 weeks that everything is completely finalized. Belfour went out of their way for us to get some last minute renovations done. We've had some folks from the gas lines come in and install all our gas lines and gas tanks. And thank God for my ladies in the office who helped us mount the incubator up on the new stand the other day. So amazing job, team. I love you all. Thank you for all the hard work you do for me every day and for us and for all of our patients. So yeah, very, very soon we should be ready to go. Okay. How long does it typically take to finish a round of IVF from starting point to implantation? Oh, that's a fantastic question. It is highly variable on what we are doing. So there's really kind of two approaches to IVF with some subtle sort of other approaches. But the main one is you're going to do an IVF cycle and do a fresh embryo transfer. So from starting it to the point where you would do the embryo transfer, it would be a minimum of, say, 11 days. That would be like a 8-day stem, which would be really, really short, making the embryos and transferring super early, which is kind of unheard of. But that would be the absolute minimum. And a maximum of, let's say, 11 or 12 days of stem. We do try to avoid the 12th day because it's not as good as doing a day 11 retrieval. And then a 5-day embryo transfer. So you might get out as far as about 16 or 17 days. So that's typical from start to finish. However, the other approach to it is to do it with a frozen embryo transfer. And when we're using a frozen embryo transfer, typically what happens is you go through that 16, 17 day cycle to create your embryos. We freeze them, and then we will bring you back 1 or even 2 months later after your estrogen levels have returned to normal. If you are producing a high number of eggs, if you have endometriosis, or if you are doing pre-implantation genetic testing because you have one of the criteria that suggests that it may be beneficial for you, then those patients need to have some time gap between the actual retrieval and creation of the embryos and the time at which they're actually transferring. So for us, typically we find somewhere between 1 to 2 months, although again, it does depend on your diagnosis. More than ample data to demonstrate, for example, that endometriosis patients need a longer interval from the time that we've done their IVF, where you're supercharging the endo to the point where you're doing the IVF embryo transfer at, let's say, 3 months, and they've been on medication to kind of suppress the endometriosis. Okay, here's a really interesting question. Hi, I had a question about serrapeptase enzymes unblocking tubes last week. Another HSG was performed and my remaining tube is open and my fibroid has dissolved. I am now pregnant. That's amazing. Fibroids don't dissolve, so that's not possible biologically. So it may have shrunken, but it's basically almost impossible to get them to fully dissolve. The best medication that we have for that is probably fibristol or ulipristal acetate, and the most they've ever demonstrated is a 75% reduction in the volume of a fibroid. Typically more like 50% at 6 months. Some patients can get up to about 75% at a year. I did look up serrapeptase. We even tried multiple spellings. There is not one single paper that we could find on PubMed suggesting that it works. So it's off-label. I'm really happy to hear that it worked for you. I'm not going to jump on board that one until I have adequate scientific proof that it's working for people. But certainly if it's something that does show a benefit, I'm super happy to try it. And if it's got no harms, that's great. The problem with the IVF world and infertility world in general is that whether you're a patient or a physician, we all desperately want things to work for you. And a lot of people will jump on board and try things when there isn't adequate evidence. Pre-implantation genetic testing is a very good example. The ERA we've discussed before is a good example. And I myself got hooked onto those things thinking that they were really good things to do for patients, and then found out later on that it doesn't appear to be that useful. So, if there's adequate evidence for things out there, for sure, you should do it. But if there isn't adequate evidence for it, I would definitely hold off because we don't know if it's beneficial or not. And sometimes the claims that are being made are simply, not reasonable or even possible. So for sure, if it worked for you, that's wonderful. Let's all stay on top of it. And I'd certainly like to hear from all of you. If others out there have tried it and used it, let us know your thoughts. Share with the rest of us and comment, and we'll definitely have a robust discussion on Instagram or any of the other social media platforms that we use. Okay, back to Facebook. What are your thoughts on going to a new fertility clinic? If you have given me more information in a 1-minute answer than they have given me in 8 months, can files be transferred from one clinic to another, or do you recommend getting all the preliminary tests done again? Sure. So first of all, I love doing this for you guys. So if I can help you no matter where you are, I'm really happy to be doing that. We don't do this to make ourselves the most popular place in town or in the province or the country or the continent. We do this because we really want to reach out and help you guys. But the answer is yes. If you want to go to any other clinic, whether it's us or somebody else, files can definitely be transferred. Certainly in Canada, you own your medical record, so you are entitled to a copy. They can charge you for it, and most places probably will. But you can get your records and transfer to another clinic. Depending on what they did for you and how long ago they did it for you, we may or may not want to do new tests for you, and sometimes that's appropriate. Sometimes I've got all the stuff I already need. So by all means, if you want to reach out to us, you can contact us through our website, and we will be more than happy to make an appointment and see you, or you can contact us at the office, 519-944-6400. Leave a message. We will get back to you. We always do. Our team is amazing, and they will reach out first chance they get. Okay. In my first 2-week wait after our second transfer with you, odd thought, is sitting at a desk for prolonged periods or sleeping on your side okay for uterine blood flow? Praying for this chance. Sure. We are praying along with you, so that's amazing. I'm a religious guy, for those of you that know me, so prayer is an important part of my life. So God bless, and we hope it works for you. Sitting at a desk is probably not a problem. If anything, biologically speaking and anatomically speaking, it should keep more of your blood flow, hopefully north of your legs. But yeah, I mean, get up and walk around. You never want to be sort of stagnant with your blood flow. The other thing is that when you are pregnant, and certainly if you're on estrogen, you are at a higher risk of forming blood clots. And if you're sitting for a prolonged period of time, some of the blood can kind of pool in your legs. You don't want to be at risk for a blood clot. So definitely get up and walk around. Sleeping on your side or even sleeping on your back at this stage in a pregnancy, very early on, has no risk whatsoever. It's only after the uterus reaches the level of the bifurcation of your aorta. So your aorta is your main blood vessel, comes down from your heart, splits off in two different directions. When your uterus falls on that point, it's actually occluding your big vein, which is your inferior vena cava. That then restricts blood from getting to your heart. Your heart recognizes that and starts pumping blood preferentially to the brain and the heart and not to the uterus, and then it's a risk for miscarriage or stillbirth. So if you're over 20 weeks or so, don't lie flat on your back, but if you are under 20 weeks, it's not a risk. And actually, there was a recent study, I haven't fully had a chance to read yet, but they were actually suggesting that it's not a problem even lying on your back in pregnancy. But there are other studies that show that it does affect blood flow even within 30 seconds of being flat on your back. So if you're coming in to do a C-section or you're coming in to deliver, we always put a wedge underneath you or keep you on your side. So flat on your back later in pregnancy is a problem, not this early on. Sitting at the desk, get up and stand up every few minutes. If you have one of those modern, Fitbits or Apple Watches or one of those, it basically reminds you anyways, so it's pretty easy to remember. Okay, how long do you usually continue melatonin until transfer or longer? Yeah, actually, some of the studies that have looked at it, looked at doing this for quite some time, even up to weeks or months into the pregnancy. So you can continue it for quite some time. I'd probably stop after 12 weeks, but we need more data on that. There aren't enough studies yet to give you a concrete answer on that. Okay, can fibroids grow during pregnancy? Mine isn't in the cavity itself and is only 1 centimeter without obstructing the shape of my uterus, but can it grow and change with pregnancy? Yeah, we got lots of fibroid questions tonight. This is great. I actually wrote a chapter for a textbook on fibroids, so I read about 250 articles and spent about 6 months of my life typing. So it's kind of a hobby topic for me, and I love this topic. So yes, they can grow. About 33% or 1/3 of fibroids will grow during pregnancy. 1/3 will stay the same and 1/3 will shrink. If it's only a 1 centimeter fibroid, I really wouldn't worry about it, especially if it's out of the cavity. Extraordinarily unlikely to have any impact for you. So that's not a concern at all. I have a septate uterus, so that's when the inside of the uterus is heart-shaped and the outside is normal. And just found out I'm pregnant. Will an early ultrasound be able to show if the baby has implanted in a viable area? I'm having a hard time getting excited. Okay, so congratulations on being pregnant. That's awesome. And a septate uterus is known to increase the risks of miscarriage. So yes, there is an increased risk, but there are loads of women out there who successfully navigate through their pregnancy with no complications from a septate uterus, regardless of where the embryo implants. There is a theoretical concern that at the point of the division, there is less blood flow, and that for some reason, some embryos like to implant there, and because they're implanting in an area with lower blood flow, your miscarriage risk is higher. Frequently, if it is a significant septum, so sort of 1.5 centimeters or more, we will resect them. So we can go in with a camera and just cut that back. And with some luck, it doesn't come back, although sometimes they immediately sort of stick back together and you even have to operate again. But I definitely want you to be cautious, but it's always good to be hopeful. You can do serial beta HCG, so it should be rising by a minimum of 60% every 48 hours, at least in the early phase, and get an early ultrasound around 6 weeks and then a repeat sort of weekly for 7 and 8 weeks. If you're getting past that point, the chances something concerning are going to happen definitely drop off and you're probably safe. So for sure, be excited. Anytime you're pregnant, you should be excited. We want it to be a joyous occasion, but be cautious and be guarded as well. Miscarriage rates can be high depending on what your status is, and so we definitely want to make sure that you are not putting all of your hope into this and then get devastated later on. So hopeful yes, cautious yes. Hopefully that answers that for you. Okay, how many times can you do natural cycle monitoring at your clinic? You can do it as many times as you like. The problem is it's not actually that helpful. So I know a lot of clinics that are not us, I won't specify names, really bring patients in for months at a time, repetitively doing just natural cycle monitoring. Are you growing an egg? What does your lining look like? When does it release? What are your hormones doing? This is actually very, very useful if I am trying to make money, because we can bill OHIP for those tests. But we never do that unless there's something very, very unusual about your first monitored cycle, because we basically get the information we need from your first monitored cycle. And beyond that, we're actually wasting your time and everybody's Canadian tax dollars. So I'm not fond of doing that. I will only do it when it is medically justified. If you're trying to do monitoring for timed intercourse, that's definitely a different story. So if you're looking at trying to see when you're releasing your egg because you can't tell on your own, that's totally legitimate, and we're more than happy to do that for you as many times as necessary. So definitely discuss it with us. We will help you out any way we can. What do you usually do during laparoscopic surgery for unexplained fertility? Would it be beneficial before doing IUI? Oh, I love that topic. Okay, so I am an advanced minimally invasive surgeon. I do a high volume casework of laparoscopic and hysteroscopic surgery, including things like hysterectomy, myomectomies, all sorts of hysteroscopic procedures, cyst removal, endometriosis treatment, and tuboplasties as well. So unexplained infertility, as I've talked about before, has just 4 treatments. So pills and insemination, shots and insemination, IVF, and surgery. And what we're really looking for is something we have not detected at the time of your other investigations with things like ultrasound and blood tests. So examples would be damage to your fallopian tubes, swollen tubes, adhesions, scarring, evidence of previous damage to the uterus or, again, the fallopian tubes, the ovaries. Sometimes your tube can be open, but it's stuck. So it's sort of stuck up here and your ovary is down here and the tube can't kind of grab the egg away from the ovary. So it may be open, but not actually functional. So those are the kinds of things we're looking for. Endometriosis is really number 1 on the list. That's a big one that we're checking for. So that's what we're looking for when we're doing your laparoscopy. It can definitely be beneficial before doing IUI. So if you have adhesion, scarring, your tubes are damaged, they're not functional, IUI is useless. So you could be wasting your time. If you have endometriosis, treating surgically can improve the success rates. The problem is you've got to weigh the risks and benefits of the surgery against the chances of success with IUI, which are modest at best. So frequently we will book you for surgery, try a couple of IUI, and then if that's not working, you're ready for the surgery. So you haven't kind of used up the time waiting for the surgery, and at the same time, your surgery is around the corner if you need it, so you're not losing any time as well. Okay. We've got someone talking about melatonin. I have read that melatonin, outside the context of IVF, may not be best for women trying to conceive naturally, as it could cause a disruption in the natural hormone balance and interfere with ovulation. What are your recommendations on that with trying to conceive naturally? Is melatonin in the low dose still beneficial to take, or just when journeying through IVF? I'm not aware of any rigorous scientific data, and there certainly weren't any for melatonin use in natural conception cycles. So I can't tell you for sure if it's beneficial, but we do know that melatonin has extensive antioxidant properties we talked about earlier, and antioxidant properties are definitely going to be good in any type of conception process, whether it's artificial or natural. So it likely is not harmful, and melatonin does not disrupt FSH and LH unless you're taking very high doses or you're really trying to play with the hormones in a strange way. So for example, if you're exhausted constantly and you're trying to use it to sleep, but your sleep cycle is all screwed up, that can wreak havoc with all your hormones. So, hormones have an enormous amount of interplay. So there's certainly the potential that it could cause some trouble, but generally speaking, it should be okay. I'm going to skip back to Instagram for a second. Why do I keep getting a cyst when I'm doing shots? You shouldn't be getting a cyst when you're doing shots. You may be getting follicles that are developing, but you shouldn't be getting cysts, and it depends on which shots you're referring to. So I need more info to answer that. What is organic conceptions? Organic conceptions is this is free advertising for my friends at Organic Conceptions. Organic Conceptions is an online program designed by a couple that went through infertility, and they found it in sort of enormously emotionally and psychologically taxing and burdensome for them. So they came up with a whole online web-based platform where they reach out to patients through this platform and are able to kind of help you navigate through all of the different stages of dealing with your infertility journey, including all of the ups and downs. And for those of you that are going through it, my most sincere, heartfelt sympathy. There are a lot of ups and downs. It's amazing when it works and the smiles and the tears of joy, and it is devastating when it doesn't. And the waiting can be frustrating, and the process can be frustrating, and God knows the costs can be frustrating. So Organic Conceptions is this online service that allows you to access the platform that they have, where they go through a workbook and they teach you how to deal with the emotions that you're experiencing as you navigate through this process. For us, I just pay for my whole patient population to have it, so that comes out of my resources, but then you don't have to pay for it. You can actually access it yourself if you're not one of our patients. And it's, I think they said it was about $80 for patients, US, for patients to access it online. You can find them online and look it up. But if you're one of our patients, just talk to me and we send you the e-invite, and then you don't have to pay for it at all. Is it normal to have pain during ovulation time? If yes, is it a good sign? Yeah, we touched on that earlier. It's quite common, and it's probably a reasonable sign that you are ovulating. Okay, we're kind of getting down to the last few minutes. I'm going to turn back to Facebook. Does the Sarnia Clinic offer a nutritionist? If not, can they refer me to one? We are going to have a new space in Sarnia very, very shortly. We are just moving into our new office. We may even be seeing patients there this month. Definitely by next month we will. And we are going to be having a nutritionist there. So yes, we will have one, and let us know. Talk to any of the amazing staff down there, and they will set you up with that. So yeah, we do have that, and we will have one here in our Windsor office very soon too. That's an important part of taking care of our patients, and we've been wanting that for a while. Okay, my husband and I would like to try for our second child. We got pregnant with our first daughter through IUI after trying for 3.5 years. Wow, that is some real stamina. It wasn't really explained as to why we were having such a hard time conceiving, but how long would you suggest we try on our own before reaching out for help? There's real easy guidelines for that. So if your periods are regular and you are under the age of 35, it's a year. If your periods are regular and you are over the age of 35 but up to 40, you want to try for 6 months. And if you're over 40, even in 3 months, you should present yourself. If your periods are irregular, meaning they are less than 21 days or more than 35 days, you should be seeing us right away. There is no point in waiting. As for why you didn't find out what was wrong, if you had unexplained infertility, that's a different story, but everybody should know what their diagnosis is. So personally for me, if you have unexplained infertility, I actually tell you, you have unexplained infertility. And so that way, if you decide to go somewhere else or you end up in a move or anything, you at least know what your history was and what you need to pass on to the next physician. So make sure you know what your diagnosis was. They must have information, so they should be able to share it with you. I just had my IUI at the Sarnia Clinic Monday. Go Sarnia, I love you guys. I forgot to ask when I'm able to have a bath, and also how long do you hold off on sex? Actually, you can have sex right away. It's not a problem. I just tell everybody, please don't swing from the chandelier and put away the 50 Shades of Grey kit. So gentle sex, nothing too crazy. And as far as bath, don't go into a really hot bath because that can distract blood flow from the uterus. But a reasonable temperature bath is fine at any time. I've got my social media guy here blushing with the 50 Shades of Grey stuff. I just had my IUI. Oh, sorry. Thank you for doing this each week, Dr. Victory. It is an amazing thing for myself and many others. Thanks for watching, guys, and thank you for thanking us. You know, the likes are helpful for us, so always like. That's awesome. Lots of sharing. We really want to build up our community. You know, get lots of followers, and that way we can reach out to more people. And it's really exponential when you get more and more followers. It really builds. So this is amazing of all of you to watch, and thank you for taking an hour out of your time to watch us each week. We love you guys for that, so that's quite amazing. Okay, so should I try to avoid sugar, sweets during the IVF process? And when trying to conceive naturally, any other diet recommendations? Sure. So if you guys have watched before, we've had Dr. Jennifer Strong, our naturopath, on with us, and that also is on our YouTube channel and probably on Facebook still too. Yeah. So you can see us on Facebook. Look for the one with Jennifer Strong, lovely curly hair. Looks absolutely nothing like my ugly mug. So she has lots of recommendations on what kind of nutrition you should be following. We'll probably pull a nutritionist on, but yes, you should avoid excess sugars, processed sugars. Natural sugars are okay, but again, not in excess. So a lot of sugar can cause inflammation, and as we've talked about all night, inflammation is not good for your IVF success rates or any fertility success. So keep it reasonable. Diet recommendations, Mediterranean diet. I just did an Instagram post on pineapple. So lots of fresh vegetables, some fresh fruits. Avoid things that have been exposed to a lot of processing, a lot of high fat diets, high sugar diets for sure. Keep it really healthy as much as you can. Hello, you prescribed aspirin and progesterone. Can you explain where I should start, and do I need folic acid as well? Okay, so basics for any fertility patient. Loads of vitamins, including your prenatal. Definitely vitamin D. You should be taking minimum of 2,000 units per day, and if you can, get your levels checked. We use aspirin in a lot of our patients. I am an aspirin believer. I think the data is there, and we talked about that before. And again, there's fertility. Did we do a fertility factor fiction on? Yeah, we just did one. And there's an Instagram post on it as well. So aspirin's great. I think it's good. And for aspirin, you can start at any time. It doesn't matter, but definitely start before the pregnancy. There was that recent study which showed that aspirin can reduce preterm labor. And then there's lots of studies that have shown that it can be beneficial, but also some that have shown it's not beneficial for fertility. I think those are all hampered by the fact that they started the aspirin too late. So start it before you even begin. Folic acid should be part of your prenatal vitamin, so you should be on it then. And progesterone is critical that you start at the right time. Too early and it's birth control, too late and it's probably useless. So you need an ovulation predictor kit. When your kit is positive, you're really probably releasing the egg the next day or within 24 hours or so. And about 24 hours after that, you should start your progesterone. So 2 days after your ovulation predictor kit is positive. Hopefully that helps. I think this will probably be the last question. What are some ways to increase sperm count? Don't drink, don't smoke, don't use drugs, stay away from heat, loads and loads of vitamins, ejaculate every 2 days, and every day for a couple of days in a row is okay as well. Keep your stress level low, keep the boys loose, don't wear tight pants or tight fitting underwear, and keep them cool. Sitting on frozen material or frozen peas helps. There's a company that produces ProFertile vitamins, or at least supports their sale in Canada, and they also have a product where it's a sort of device you can freeze and it will cool your testicles for you. So those are all helpful hints. Okay, it's 8:59. Thank you again for joining us on Fertility Fact or Fiction. Remember, it's a fact. Melatonin can help you if you're doing infertility treatments, and we will reach out to you guys again next Monday on Fertility Fact or Fiction. Thanks again for joining. Like, comment, share. We will definitely get back to you with your questions. Love all of you guys. Thanks for watching, and tune in next week.